Okay. So now that I know how to move the slides, I want to just start off with an introduction to say that this disease that we are all focusing on today began in the 1861 with Dr. Duchenne de Boulogne, and he described how of boys with muscle weakness as well as very bulky, almost powerful looking appearance to their muscles. So he described this, and then the gentleman to the right, Dr. William Gowers, described the way in which boys intuitively learn how to get up, and the Gower sign, these are the words that we use to communicate, and this is how we can try to recognize this condition today. So it took another 100 years later. There are two groups that I've highlighted here. Dr. Peter Ray, Dr. Wharton from the Sick Kids Hospital described the location of this gene on the X chromosome relating to Duchenne muscular dystrophy. And then Dr. Eric Hoffman, Dr. Lou Konko, and their team followed and described this dystrophin protein, which is missing because of this change in the genetic code in the X chromosome, and we named that gene the DMD gene. So we understand now that this is a protein that spans across. So this protein is in this cartoon shown like this. It's a big protein. It's one of the largest protein that we make in our body. And this is a diagram contained within the muscle cell, how this protein is essential as a structural support for the elements in the muscle that contracts, and how it links with the supporting element outside of each cell. And this protein, the dystrophin protein, is essential to keep everything in together. So with the change in the genetic code, in which we use the word mutation, when this mutation occurs, that protein does not function or it's totally absent, and then it disrupts the whole integrity of each cell, and then that leads to the progressive muscle weakness. So as we can see in this picture in front of you, in two boys aged 5 and 7, they are siblings, and that there is a change in the shape of the muscle, and the muscle cells with time, because of the weakness, it's then changed to be replaced by scar tissue as well as fat. And with time, the amount of fatty replacement and scar tissue increases. So that's why there is increasing muscle weakness. And we can see that with a method of staining the cell, we know that the dystrophin protein is absent in boys with this condition, whereas normally it should be surrounding each individual muscle cell. Think of it as protecting the muscle against the damage from movements. So the overview, the first part of what my talk is to say that there are lots of now new development, and this is from the Parent Project website, which is a great resources for families to look at what is new and coming. And the latest development has an interactive component for you to be able to find out whether your son may be a good candidate to participate in these trials. And I'm just going to say that there are ways of fighting the inflammation and the scar tissue that is part of this deterioration. There are also ways to help to maintain muscle growth and to protect them against the damage from the breakage of the muscle membrane. There are ways to increase the wellness of the muscle by increasing blood flow, by helping the cell energy to work better. Those are the mitochondria. And these are all going to be, part of this joint effort to help boys with Duchenne. I'm just going to focus as an overview to talk about ways of increasing the protein that is missing in the cell membrane, or how to correct the genetic mutation in order for us to see this reverse to be able to maintain the muscle function. So there are a few things that I just want to highlight, and you'll hear about them a lot in depth further with the speakers that are to come. The first is you heard about the stop codon suppression with PTC therapeutics. So this is an outline, again, a diagram to tell us that our genetic code is made in pair with what we call base pair. They join together, and this is actually an unfolded picture of our DNA, which is our blueprint. And in our blueprint, they are shaped by groups of 3 of these base pairs. And when there is an addition or missing or deletion of the genetic code in the dystrophin gene, for example, it changes the reading frame. It changes the way in which the protein is being made. And so in cases of nonsense mutation, which affects about 10 to 15% of boys with DMD, the message is such that once you change the base pair codes, then it tells the body to stop making the protein. And that is only unique to those individuals with a nonsense mutation related DMD. So what can we do when we see that there is a stop codon? So the message here is in this first slide again, on the top you can see that there is a stop message to the cell, and then it does not allow the full protein to be made, and so that's why there is an incomplete protein that is being removed by the body. And then in the case of Adalorant, Translarna, drug is specifically targeted to bind to the way that the body reads through our genetic code. It actually make this mechanism work by stopping this nonsense codon and bypassing it, which is then shown in this next little cartoon here. So Adalorant binds with the reading mechanism to make the protein. It bypasses the nonsense mutation, and then it says go ahead, and it continues to make, and then the end product is that of a partially restored dystrophin protein. So that is a cartoon to help us understand how this drug works. And the data in there are 2 studies that I'm presenting just to show you that in the phase 2B trial, we can see using how far a boy would walk in a 6-minute time period. It does show that there is a difference between those boys in blue who are treated versus those who are not treated, a distance difference of over 30 meters. And so this is a significant finding, and it prompted the second study, which was published in the Lancet in 2017, and I just took out a picture of one of the slides that shows that the boys who are at a distance of between 300 to 400 meters seems to do the best with Adalorant trial and showing a difference of 47 meters. The rest of the cohort, because of various stages of their experience with Duchenne, the whole group does not have such an impressive outcome, and so that's why there are more studies that are to come with Adalorant in hope to get it finally approved by Canada and the United States. The next example I'm going to quickly review is about exon skipping. And what is exon skipping? The idea of exon skipping is that we have seen that picture about how addition or deletion of one part of the genetic code can lead to a change in the way in which the body reads the genetic code. So in the case of an out-of-frame mutation, which typically causes Duchenne, with the deletion of exon 50, this is just one of thousands of ways in which there could be a mutation. We can see that when you delete the exon 50, then the way in which the protein is read, because it is what we call out of frame, it does not make sense. And so then at some point this whole message became unscrambled, it does not allow the whole protein to be made, and as a consequence, it stops, and the protein is then no longer being made. So exon skipping is to use an antisense oligonucleotide. You will hear about this, and Dr. Toshi will be discussing at depth. This is the nature of his research, and I'm just using a simple diagram to show you that when we have the same mutation in a boy who has deletion of exon 50, and if we use an antisense oligonucleotide, it binds to exon 51, and then when the body reads this message code, it actually will be able to change it from an outer frame to an in frame. In frame means that the body is still able to recognize the message decoded, and what follows then is the change of code leads to the ability to synthesize a modified protein, and that itself is enough to show enough of a protein to help these individuals with the specific mutation. So as an example of this graph taken from the paper by eteplirsen, which is an exon 51 design drug by Sarepta Pharmaceuticals, the 3-year data shows that those 12 boys who received this treatment after 3 years showed a significant improvement in their ability in black, those are the boys, in black, in their ability to maintain a good amount of walking ability in their 6-minute walk test compared to a comparison group of boys who start out being in the same with similar characteristics, but over time lose the ability to walk. And the maintain of the muscle function continues now, and Sarepta, as well as other company, continues to use exon skipping as a strategy for different mutations, 45, 51, 53, and multiple exon skipping that you will hear about. Thirdly, I want to talk about this idea of restoring the genetic code using microdystrophin gene therapy. And the idea is that we have a big protein. Dystrophin gene is a very big gene. So how do we replace it correctly? And that is a challenge. So now what we do is that the idea of microdystrophin gene replacement is to use the virus, and in this case, a virus that has been found to be harmless and basically becomes a carrier because the viral protein has been removed except for the capsule. And then you embed a small but important part of the dystrophin gene inserted called microdystrophin shortened. And then you put it into this capsule, and then it has ability to get into the muscle cell. And then once it does so, it then causes the integration of this part of the gene into the cell nucleus, which is the messaging center to make to the protein that is missing, and then restore the protein in the muscle membrane. So this is a strategy that's being worked on by a number of companies, and I just have a table here to describe the nature of using the virus capsule to bring in a gene to help to restore the protein or to increase the ability for the cell membrane to compensate for the muscle damage. And you will be seeing more and more of this type of research and the results to come. The last thing I want to just touch on very briefly is the work that is related to gene editing and the way of how it can potentially help restore the mutations that are in our children with Duchenne muscular dystrophy. So the nature of gene editing relies on the success of research related to use of different viruses as a carrier, and then this gene editing ability, and you've heard about this CRISPR-Cas9. So I'm just going to use a slide to say that basically when you hear CRISPR-Cas9, it is just a very elegant term of scientists describing the use of this model as a way to go into the genetic code, and it's like a way of cutting into the the mutation that we see here with a guide, and then opening it up and cutting the defective area so that then you can bring in the correction using a viral capsule, for example, and then correcting the genetic code. So this is definitely an excitement. We have already seen the work in muscle cells in a dish. We've also seen it now in animal models of mice with the dystrophin gene mutation. And I think that this is the work that is going to follow, not only for muscle disease, but a whole host of other genetic disorders. And the hope, of course, is that it is one of those possible one-time treatment that can lead to long-term benefit and potentially cure without needing repeated treatment. So we're all looking forward to this development for Duchenne. So meanwhile, the work is ongoing to support you as parents of boys and youth with this genetic condition. And there are 3 new papers for researchers, scientists, and doctors involved, and they clearly outline the different ways in which we can maximize the benefit of treatment and support for Duchenne muscular dystrophy. And I would ask you to, if you haven't already done so, to go into and Google Duchenne Guide for Families 2018 Standard of Care, because it does have a lot of very useful information written in a way that makes it easy for us all to understand how to do the best to help maintain function. So I'm just going to give you an overview of some examples. So this is the way in which we see you as the head and center of this whole care. It is what we call multidisciplinary, meaning that there are many team doctors and specialists responsible to help, but you remain in the center, you working with your child with DMD are the focus, and you help us to direct. I would like to say that the care coordinator is absolutely essential. So for the Children's Hospital, Shannon is our clinic nurse, but she serves the important function of being the coordinator of the program. And you can see that there are many specialists like neurologists, orthopedic doctor, lung doctors, heart specialists, GI with the digestion, nutrition, and endocrinologists. They all play a role. They don't all need to be involved in all through, but as the different stages from diagnosis to adolescence and to young adulthood, they all may play a role in taking care of your child. So if we talk about treatment, right now still corticosteroids, prednisone, deflazacort remain cornerstone, and we recognize this from the first standard of care document in 2010 that it plays a key role in maintaining function and delaying the progression of the disease. This is an example of how we can see a comparison of boys on treatment in black compared to those who were not treated. There is a difference in the time on treatment leading to ability to walk on average at least 2 to 3 years longer. And the comparison between deflazacort and prednisone shows that in this paper that deflazacort seems to be slightly more efficacious than prednisone, but this is during the early adolescent period of time. Prednisone and deflazacort all have different side effect profile, and it's important for us to monitor. So one thing that we monitor for is how a child with Duchenne is growing, so we have to get their height measurements, and if standing is a problem, then we also use measurement of the bone growth here as a way, and ideally we want to maintain their weight as well as their height within what is acceptable. Height is certainly affected by Duchenne. Weight is even a problem, and we ideally want to maintain them between the 10th and 85th percentile of their body mass index, which is a calculation that we can do in the clinic based on measurements of height and weight. Increasingly, bone health has been a focus, and you all know the importance of calcium-rich diet, as well as supplement with vitamin D, because we live in Canada where we don't get enough natural sunlight. And you will see that your child will have spine x-ray as well as bone density x-ray on average every 2 to 3 years. And if there is any concern about bone pain or the tendency for bones to be too fragile, then there is a treatment called bisphosphonates, which is infused every 3 to 6 months to help reshape and strengthen the bone. It is still not approved for use for every child with Duchenne, but certainly it is a treatment that can be helpful if there is a tendency for fractures to occur. We also advise that breathing function should be measured as early as a child can cooperate, and at 6 years that is usually our starting point. If there is symptoms to suggest that they're not breathing well on their own, as with sleep apnea, then we will start doing a sleep study earlier, or if there is a change in their breathing function with the pulmonary function test. There are strategies that can help with working and strengthening the breathing muscles, and that is called breath stacking or lung volume recruitment, which is a whole mouthful, so we call it LVR. And we also teach families how to do cough to effectively clear secretions, especially during a cold, and that there are positive pressure support, breathing support that can help the lung to really expand fully, to help young people with Duchenne to feel energized if they have a good sleep and an adequate amount of oxygenation during the night. Cardiac care, the new advances recommend that a child with Duchenne muscular dystrophy have annual cardiac checkup. So heart tracing, ECG, echocardiogram, which is an ultrasound, and that the trend is to start prevention treatment early at or before 10 years of age. And the first drug is a drug which is called angiotensin converting enzyme. It just helps to relax the blood vessels in order for the heart not to have to work so hard to pump, because as they continue to work hard, then the heart muscles can get bigger. And so that is a problem that we try to be more proactive now with the 2018 guidelines. Orthopedic care, we have orthopedic surgeons. We talk about, using night splints to help stretch the ankles. And Angela Chu, our very experienced physiotherapist, has been a great help to us, and she will talk more about this. There are other physical therapy as well as ways of helping boys to get the exercise and mobility. And x-rays are usually done every 6 to 12 months. So there are lots of things here in this slide, and I think that this is where we need you to be in touch and have access to a family doctor or other support like a pediatrician if it is necessary. Things like vaccination, flu shots every year, pneumococcal vaccination, which is to prevent against the pneumococcus, a bacteria. We recommend that to be done and updated at least every 5 years. Flu vaccine every year, eye checkup, dental checkup, we all need it, and so do boys with DMD. Diet and exercise, use of equipment, please make sure that they are all in tune with the growth of your child. And the challenge here is the changes that are to come in puberty, and that's why we have, we actually have a consultation with other specialists. One thing to bear in mind that because boys on Duchenne, on steroids for Duchenne, they are at risk for not mounting a stress response. So any kind of surgery, it needs to be planned. Any emergency or illnesses for which your child cannot take steroids for more than 24 hours, that constitute a need to contact us or the emergency care team if they are vomiting in order for us to replace steroid in case, so that they will not suffer from what we call adrenal insufficiency. And the family guide outlined that very carefully for you. So transition care is a time-consuming process. It doesn't happen at one visit. We start transitioning, and there are resources through the Family Guide as well as the MD Association Jesse Journey, as well as other parent organizations like PM Parent Project. And the idea is to plan early, so mid-adolescence, 12, 13, 14 years. There is a transition clinic that is in place at the Children's Hospital that will start, and we also have been working with our adult neuromuscular and physiatry colleagues. The transition needs are going to be quite different because we are looking at young adults. They have worked well with the pediatric team. Now we are getting them to move forward to the adult programs. We need to look at, their educational needs, transportation, housing, employment, activity, and ongoing healthcare monitoring. So it's a very complicated dimension, but these are things that we need to be prepared for, and I ask you to help us to make sure that we cover those topics adequately. I'd like to end by saying that this is really, a great day. And I have learned so much from you all. I do think that amidst of all these various activities and opportunities happen, I want to make sure that we all appreciate how important every day is. To be able to live fully, to be able to appreciate that the moment that we have is precious, so that we do not get carried away and forget to live in the present. And I really appreciate the reminder from the quote from this mother of a young adult, and I am so grateful for all your participation, volunteering, as well as your engagement in making sure that we do the best that we can as a team together to make it work. I cannot do this work without your support, and I'm very grateful to be in partnership with you all to help our boys and our young adults with DMD to do the best that they can and to enjoy this experience together. So thank you very much.